Today we will see about diseases of orbit. Bony orbit. Bony orbit is the quadrangular truncated pyramid situated between anterior cranial fossa above and maxillary sinus below. It is formed by precision of 7 bones: frontal, maxilla, zygomatic, sphenoid and palatine, ethmoid and lacrimal bone. It has 4 walls: medial, lateral, superior and inferior, base and apex. Then middle walls of orbit, 2 orbits are parallel to each other. Inferior orbit wall is triangular in shape. Then lateral wall of triangular in shape. Roof of orbit is triangular in shape. Base is anterior open end of orbit. Orbital apex is posterior end of orbit. Then orbital fascia, it is thin connective tissue membrane lining various intraorbital structures. Then schematic coronal section through orbits and nasal cavity. Frontal bone, sphenoid, zygomatic, vomer, maxilla, palate, inferior nasal concha, perpendicular plate, middle nasal concha, superior nasal concha, and cavity of orbit, cribriform plate, crista galli, etc. Then schematic view: orbital plate of greater wing of sphenoid, lateral orbital tubercle, superior orbital fissure, orbital plate of zygomatic, sphenoid, zygomatic, optic canal, lacrimal bone, ethmoid bone, maxilla, orbital plate of maxilla, supraorbital notch. Contents of orbit: eyeball, volume of orbit is 30 cc. Current single, optic nerve, lacrimal sac, extraocular muscle, ophthalmic artery, its branches, 3rd, 4th and 6th cranial nerve, ophthalmic and maxillary division of 5th cranial nerve, sympathetic nerve, orbital fat and fascia. Surgical space in orbit: superior periosteal space. Each orbit is divided into 4 surgical spaces. Subperiosteal space. One is subperiosteal space. This is sagittal section, and below are coronal sections. Then 2 is peripheral space. 3 is central space. 4 is tenon space, inside the tenon's capsule. Then 5 is peripheral and central space merged with each other. Proptosis defined as forward displacement of eyeball beyond the orbital margin. Though its exophthalmos is synonymous with it, but somehow it has become customary to use the term exophthalmos for the displacement associated with thyroid eye disease. Then classification: unilateral, bilateral, acute, intermittent, pulsating. 5 types are there. Then etiology: cause of unilateral proptosis. Unilateral proptosis is caused due to congenital conditions. These include dermoid, cystic, congenital cystic eyeball, orbital teratoma, etc. Traumatic lesions. Orbital hemorrhage, retained intraorbital foreign body, traumatic aneurysm, inflammatory lesions, acute inflammation or orbital cellulitis, abscess, thrombophlebitis, panophthalmitis, cavernous sinus thrombosis, etc. Circulatory disturbances and vascular lesions, cysts of orbit, tumors of orbit, mucosals of paranasal sinus. Then cause of bilateral proptosis: developmental anomalies of skull, craniofacial dysostosis, osteopathies, osteodeformans, inflammatory conditions, Mikulicz syndrome, endocrinal exophthalmos, tumors, lymphosarcoma, secondaries from neuroblastoma, nephroblastoma, Ewing sarcoma, etc. Then systemic disease: histiocytosis, systemic amyloidosis, xanthomatosis, venous granulomatosis. Cause of acute proptosis: it develops extremely rapid, sudden onset. Cause of intermittent proptosis: appears and disappears on its own. Its common cause are orbital varix, periodic orbital edema, recurrent orbital hemorrhage, highly vascular tumors. Most important cause of intermittent is orbital varix, in which proptosis develops intermittently and rapidly in one eye. When sinus stasis is induced by forward bending or lowering of the head, turning the head forcefully, hyperextension of neck, coughing, etc. Cause of pulsatile proptosis. It is caused by pulsating vascular lesions such as carotico-cavernous fistula, sacral aneurysm of ophthalmic artery, etc. Investigation history, age, nature of onset, progression, local examination, inspection should be performed to differentiate proptosis from pseudoproptosis. Pseudoproptosis is a condition in which eyeball appears to be proptose, but actually there is no forward displacement in pseudoproptosis. The causes are ophthalmus, that is congenital glaucoma, axial high myopia, retraction of upper lid, inophthalmus of opposite eye, paralysis of extraocular muscle, stimulation of mullar muscle by cocaine, shallow orbits as in craniofacial dysostosis. To ascertain whether proptosis is unilateral or bilateral, to note the shape of skull, to observe whether proptosis is axial or eccentrical. Axial proptosis is a feature of intracorneal masses and thyroid ophthalmopathy. Eccentric proptosis is produced by extracorneal masses as below. Medially placed mass, example ethmoid sinus mucosal tumors, subperiosteal collection will produce lateral eccentricity. Lateral placed masses, lacrimal gland enlargement will push the eyeball down and medially. Superior located mass, frontal sinus mucosal encephalocele, lacrimal gland mass, sphenoid wing meningioma, etc. Then inferior located mass, maxillary sinus tumors, lymphoproliferative disorder will produce superior displacement in the eyeball. Palpation is it should be carried out for retro displacement of globe to known, no compressibility of tumor for orbital for any swelling around the eyeball. Auscultation is its primary value is in searching of abnormal vascular communication that generate a bruit, such as carotico-cavernous fistula. Hand examination help in avoiding anterior orbital lesions. Visual acuity, the orbital lesions may reduce the visual acuity. Refractive changes due to pressure on back of eyeball, optic nerve compression, exposure keratopathy. Pupil reaction, Marcus gun pupil is suggestive of optic nerve compression. Marcus gun pupil. Fundoscopy, it may reveal venous engorgement, hemorrhage, disc edema, optic atrophy. Ocular motility is restricted in thyroid ophthalmopathy. There is exophthalmos. Exophthalmometry, it measures protrusion of apex of cornea from outer orbital margin with the eyes looking straight ahead. Normal values varies between 10 to 21. Difference of more than 2 mm between two eyes is considered significant. The simplest instrument to measure proptosis is Louis D exophthalmometry. Our hertel is also used. Hertel exophthalmometry. Perimetry is useful for assessing optic nerve function. Systemic examination, thorough examination should be conducted to rule out systemic cause of proptosis such as thyrotoxic histiocytes and primary tumors elsewhere in the body. Laboratory investigation, thyroid function test for exophthalmos. Hematology studies, TLC, DLC, ESR, Cassoni test, stool examination for cyst and ova, and urine exam for benzone protein. Hertel's exophthalmometry. Imaging techniques. Imaging technique, non-invasive techniques, plain X-ray, CT scanning, ultrasonography, magnetic resonance imaging, invasive procedures, orbital venography, carotid angiography, radioisotope arteriography. These are for orbital varix for orbital venography, carotid angiography for suspected arteriovenous malformation, radioisotope arteriography in proptosis of vascular lesions. Histopathology, FNAB, fine needle aspiration biopsy. It is reliable and accurate 95%. Weak and easily technique for sighted lines of orbital tumors. Biopsy aspirate is obtained under direct vision in an obvious mass under CT scan or EUS guidance. Incision biopsy undoubtedly for accurate tissue diagnosis or proper biopsy specimen at least 5 to 10 mm in length is required. Incision biopsy in diagnosis or orbital tumors may be undertaken along the frozen tissue study in infiltrated lesion which remain undiagnosed. Excision biopsy preferred for over incision biopsy in orbital mass which are well encapsulated or circumscribed. Then non-invasive techniques are the plain X-ray. Commonly required exposures are cold view or water view. X-ray signs of orbital disease include enlargement of orbital cavity, enlargement of optic phenomena. Then compute CT. CT is first line imaging modality for orbital disease. First line. A combination of axial CT and coronal CT could enable 3-dimensional visualization. CT is capable of visualizing structures like globe, extraocular muscle, optic nerves, etc. Disadvantage is the inability to distinguish between pathological soft tissue muscle which are radiologically isodense, radiation exposure and reaction to contrast medium. Then ultrasonography US, it is a non-radiating, non-invasive, completely safe, extremely valuable initial scanning procedure for orbital lesions. Magnetic MRI, it is a major advance in imaging techniques, very sensitive for detecting difference between normal and abnormal tissue and has excellent image resolution. Technique produces tomographic images which are superficially very similar to CT but rely on entirely different physical principles for their production. Enophthalmos is inward display of eyeball. 50% of cases mild enophthalmos are misdiagnosed as having ipsilateral ptosis or contralateral proptosis. Congenital megarethrosal maxillary hypoplasia, traumatic, post-inflammatory paralytic enophthalmos, atrophy of orbital contents. Then developmental anomalies. Developmental anomalies of orbit are commonly associated with abdominal skull facial bones. Craniosynostosis. Cells from premature closing of one or more cranial sutures. Brachycephaly, closed skull, coronal suture closed prematurely. Oxycephaly, tower shaped skull, coronal suture. Scophocephaly, boat shaped skull, sagittal suture. Trigonocephaly, egg shaped skull, frontal suture. Acrocephaly, multiple cranial suture. Craniofacial dysostosis. Craniofacial dysostosis refers to premature closure of coronal and sagittal sutures. Brachycephaly associated with maxillary hypoplasia. Inheritance is autosomal dominant, but 25% cases occurs as fresh mutation. Ocular feature problems due to shallow orbits, V pattern exotropia, hypertropia, hypertelorism, widely separated eyeballs, optic atrophy. Ocular associations include blue sclera, megalocornea, aniridia, glaucoma, cataract, ectopy lentis, optic nerve hyperplasia, systemic feature, mental retardation, eye palate, irregular dentition, hooked nose. Mandibulofacial dysostosis. Ocular features include indistinct inferior orbital margin, coloboma of lower eyelid, anti-mongoloid slant. Systemic feature macrostomia, bird-like face, medial facial cleft syndrome. Main ocular features are hypertelorism, telecanthus, divergent squint. Main systemic feature cleft nose, lip, palate, V-shaped front hairline, widow's peak. Acrocephaly, syndactyly. Most severe of craniosynostosis. Tower skull, mental retardation. Ocular feature hypertelorism, increased IPD. Then divergent squint. Hypertelorism is a condition of widely separated eyeballs resulting from widely separated orbits, broad nasal bridge. Orbital infection and inflammation. Acute preceptor cellulitis, orbital cellulitis, orbital osteoporosis, chronic orbital tuberculosis, syphilis, actinomycosis, mycotic infection, mucormycosis, parasitic infections. Non-infective, isolated systemic, isolated diffuse focal, diffuse idiopathic orbital inflammatory disease, idiopathic sclerosing inflammation of orbit, focal myositis, dacroiditis, Stolz-Hunt syndrome, systemic inflammation, preceptal cellulitis. Etiology: Staphylococcus. Modes of exogenous infection may result from skin lacerations, insect bites, extension from local infections such as from acute hordeolum. Endogenous infection may occur by hemorrhagic spread from remote infection. Clinical feature: edema, inflammatory edema of eyelids, periorbital skin with no involvement of orbit. Character feature are painful acute periorbital swelling, erythema, hyperemia of lids, fever, leukocytosis may be associated. Proptosis is absent, ocular movements are normal. Conjunctiva is usually not congested. Treatment: systemic antibiotics mainstay, amoxicillin 500 by 125 mg TDS, flucloxacillin. Severe cases ceftriaxone 1 to 2 gram per day, divided doses. Analgesic to reduce pain and swelling. Orbital cellulitis refers to acute infection of soft tissue of orbit behind orbital septum. Modes of infection: exogenous, extension of infection from neighboring structures, then endogenous infection. Causative organ: Streptococcus pneumoniae, Staphylococcus aureus, Streptococcus pyogenes, Haemophilus influenza. Pathology: infection established early due to absence of lymphatics in the orbit. Rapid spread with extensive necrosis. This one is preseptal cellulitis. Then from surrounding structures, damage produces rapid extensive as orbit infection associated with raised intraorbital pressure due to tight compartment. Clinical features: swelling, severe pain, which is increased by movements of eyeball or pressure, are main symptoms. Associated general symptoms include fever, nausea, vomiting, prostration. Visual loss or diplopia may be complained by patient with moderate to advanced disease. Signs of orbital cellulitis are swelling of lids characterized by woody hardness. Redness is usually marked. Chemosis of conjunctiva, which may protrude and become desiccated or necrotic. Axial proptosis, restriction of ocular movements. RAPD may be due to optic neuropathy or compression, central retinal artery occlusion. Then fundus examination may show congestion of retinal veins, signs of papillitis or papilledema. Complication: ocular complication are usually blinding, include exposure keratopathy, optic neuritis, central retinal artery occlusion. Orbital complications: subperiosteal abscess is collection of purulent material between orbital bony wall and periosteum, most frequently located along the medial orbital wall. Clinical subperiosteal abscess is suspected when clinical features of orbital cellulitis are associated with eccentric proptosis, but diagnosis is confirmed by CT scan. Orbital abscess is collection of pus with orbital soft tissue. Clinically, it is suspected by signs of severe proptosis, marked chemosis, completely ophthalmoplegia, pus points below the conjunctiva, but is confirmed CT scan. Orbital 3-year-old female child. Orbital cellulitis in a 3-year-old female child. Temporal parotid abscess may occur due to spread of infection around the orbit. Intracranial complications include cavernous sinus thrombosis, meningitis, brain abscess. General septicemia, pyremia may occur eventually in few cases. Bacterial culture done. Complete hemogram may reveal leukocytosis. X-ray PNS to identify associated sinusitis. Then orbital ultrasonography to detect intraorbital abscess. CT scan, MRI useful in differentiating preseptal postseptal cellulitis, in detecting subperiosteal abscess, orbital abscess, in detecting intracranial extension, and in deciding when and from where to drain an orbital abscess. Treatment: antibiotic therapy for staphylococcus infection, penicillin resistant antibiotic oxacillin combined with ampicillin, cefotaxime given to cover respiratory influenza, especially in children, chloramphenicol clavulanic acid given to cover anaerobes, oral metronidazole 500 mg given every 8 hours. Analgesic anti-inflammatory to reduce pain and inflammation, topical antibiotic eye ointment, nasal decongestant drops, re-evaluation at least twice to thrice daily in hospital. Surgical intervention, it is indication include unresponsive to antibiotic, decreased vision, and presence of an orbital or subperiosteal space abscess. Surgical intervention may require as follows: immediate canthotomy, cantholysis, free incision into abscess. Subperiosteal abscess is drained by 2 to 3 cm curved incision in upper medial aspect. In most cases, it is necessary to drain both orbit as well as infected paranasal sinus. Orbital mucormycosis, etiology: mucormycosis, also known as pachyomycosis, severe fungal infection of orbit caused by mucor or rhizopus. Clinical features: pain, proptosis, necrotic area with black scar. formation may be seen on mucosa plate. Complication if not treated energetically, patient may develop meningitis, brain abscess, die within days to week. Diagnosis made clinically, confirmed biopsy of involved area. Areas of blast scar, necrosis on eyelids on patient, rhino-orbital mucormycosis. Then treatment. Treatment is often difficult. Correction of underlying disease, surgical excision, intravenous amphotericin B, excenteration, cavernous sinus thrombosis. Then septic thrombosis of cavernous sinus is a disastrous sequel, resulting from spread of sepsis traveling along its tributaries from infected sinus, teeth, ears, nose and skin of face. Very rarely cavernous sinus thrombosis may occur after trauma, head injury. Communication of cavernous sinus and source of infection. Anteriorly, superior and inferior ophthalmic veins drain in sinus. Superior and inferior ophthalmic veins drain in the cavernous sinus. Then these veins receive blood from face, nose, paranasal sinus, orbits. Then therefore infection of cavernous sinus may spread from infected facial wounds, erysipelas, squeezing of stye, furuncles, orbital cellulitis and sinusitis. Posteriorly, the superior and inferior posterior sinus, superior inferior posterior sinus, inferior petrosal sinus leave it to join the lateral sinus. Superior and inferior petrosal sinus. Labyrinthine veins opening, and into inferior petrosal sinus bring infection from middle ear. Middle ear infections are common from petrosal sinuses. Superior cavernous sinus, mastoid emissary veins may spread infection from mastoid hair cells. Mastoid emissary veins may spread infection from mastoid hair cells. Mastoid hair cells. Superior and inferior petrosal veins spread infection from middle ear. Then superiorly, the cavernous sinus communicates with veins of cerebrum, middle meningeal vein, and which may be infected by cerebral abscess. Inferiorly, sinus communicate with pterygoid venous plexus. Then medially, two cavernous sinuses are connected with each other by transverse sinus, which account for transfer of infection from one side to another. Clinical feature, the cavernous sinus thrombosis. Thrombosis starts initially as unilateral condition, which soon becomes bilateral, and in more cases, in 50% of cases, due to intercavernous communication. Then this condition is characterized by general and ocular features. General features: seriously ill, having high grade fever, chills and rigor, vomiting, headache. Ocular features: severe pain in eye, forehead and affected side. Conjunctiva is swollen, congested. Proptosis develops rapid proptosis. Ipsilateral ophthalmoplegia causing diplopia may occur due to palsy of 3rd, 4th, 6th cranial nerves. Ophthalmoplegia is sequential with 6th nerve palsy occurring first of all as it passes through cavernous sinus. 3rd and 4th nerves are involved later as they are related to lateral wall of cavernous sinus. Ipsilateral ptosis: dilated pupil, absence of direct as well as consensual pupillary light reflex. Corneal anesthesia, that is loss of corneal reflex, may occur due to involvement of ophthalmic division of 5th cranial nerve. Edema in mastoid region. Fundus may be normal with unimpaired vision in early cases. CT head and orbit show involvement of cavernous sinus and proptosis. CT head. Magnetic resonance angiography. It is the investigation of choice which shows absence of flow void in thrombosed sinus. Blood culture is recommended for sepsis. Complication at any stage: hyperpyrexia, signs of meningitis, or pulmonary infection may proceed to death. Differential diagnosis: rapidly developing acute inflammatory type of process seen in cavernous sinus thrombosis need to be differentiated from orbital cellulitis and panophthalmitis. Treatment: antibiotics, massive dose of modern potent broad spectrum antibiotic, analgesic IV, given IV, analgesic anti-inflammatory drug to control pain and fever, anticoagulant role in controversial. Then idiopathic orbital inflammatory disease, non-infective orbital inflammation. It is known as pseudotumor and for condition of orbit which clinically present as tumors but histopathically proved chronic inflammation. Then the differential diagnosis of cavernous sinus thrombosis, orbital cellulitis and panophthalmitis. Unilateral, all three are unilateral. Proptosis moderate in cavernous sinus thrombosis, marked in orbital cellulitis and panophthalmitis. It is moderate. Vision not affected in early stage, complete loss of vision from beginning. Then cornea and anterior chamber, clear in early stage, hazy due to corneal edema, pus in anterior chamber. Ocular movement, complete limitation to palsy, marked limitation, painful and limited. Edema in mastoid region, present, absent. General symptoms with fever and prostration, marked mild. Then clinical features: IOID can occur throughout the orbit from region of lacrimal gland to orbital apex. Age 40 to 50, presenting ocular features, swelling, puffiness, optic nerve dysfunction may occur, spontaneous remissions, recurrence are also common. Diagnosed clinically IOIDs only by excision of known conditions. Ultrasonic CT, MRI show hypointense lesion of T1, hyperintense lesion of on T2. Initial biopsy needed to confirm. Pseudotumor involving right orbit. Treatment: NSAIDs, systemic steroid, radiotherapy, cytotoxic agents, tumor necrosis factor inhibitor. Tolosacant refers to idiopathic non-specific granulomatous inflammation. Clinical feature: painful ophthalmic vision depending upon the extent involvement may present as superior orbital fissure syndrome. It mostly involves the superior orbital fissure. Symptom produced by involvement of structures passing through superior orbital fissure. It is caused by pain, retroorbital ache. Then sensory loss, ipsilateral ophthalmic picture, ptosis due to third nerve paralysis. Orbital apex syndrome refers to symptom complex produced by involvement of structures present at the apex of orbit. Structures passing through superior orbital fissure and optic canal. So the features of orbital apex syndrome include features of superior orbital fissure, features of optic nerve involvement. Treatment: steroids, radiotherapy. Then we will move on to thyroid exophthalmos. Thyroid eye disease. The term thyroid eye disease denotes typical ocular changes which include lid retraction, lid lag, proptosis. These changes have also been labeled as endocrine exophthalmos, malignant exophthalmos, dysthyroid ophthalmology, and ocular Graves disease, Graves ophthalmopathy, and thyroid associated ophthalmopathy. Etiopathogenesis: thyroid eye disease may be associated with hypothyroidism, or even euthyroidism, but mostly hypothyroidism. Risk factor: female, smoking, middle age, autoimmune thyroiditis, HLA DR3, HLA B8. Then pathogenesis: it is being considered as an autoimmune disease with the orbital fibroblasts as primary target of inflammatory attack. Orbital fibroblasts are primary target, extraocular muscle being secondary target. It is probable that target antigen is shared between thyroid follicle cells and orbital fibroblasts. Target antigen is shared between thyroid follicular cells and orbital fibroblasts. Activated T cells probably act on fibroblast adipocyte lineage within the orbit and stimulate adipogenesis. Fibroblast proliferation: and glycosaminoglycan synthesis. Then as a sequence, the extraocular muscles are enlarged as fibroblasts are proliferated. Then extraocular muscles are enlarged due to edema, infiltration with the round cells. The orbital soft tissue shows increased amounts of acid mucopolysaccharide and infiltration with lymphocytes, plasma cells, macrophages and mast cells. Clinical profiles, clinical features, we'll see the figure 17.11. Patient with Graves' exophthalmos, ophthalmopathy having bilateral exophthalmos with lid retraction. Then clinical profile, lid signs, retraction of upper lids producing the characteristic staring, frightened appearance. Dalrymple sign is the most common clinical feature, 90% cases. Dalrymple sign. Then lid lag, Von Griefe sign. When globe is moved downward, upper lid lags behind 50% of cases. In 50% of cases, Von Griefe syndrome. Retraction of upper lid and lid lag. Fullness of eyelids due to puffy edematous swelling, Enroth sign. Difficulty in eversion of upper lid, Gifford sign. Infrequent blinking, Stellwach sign. There are 5 signs of upper lid. The first sign is retraction, Dalrymple sign, lid lag, Von Griefe sign. Fullness of eyelid due to puffy edematous swelling, it is Enroth sign. Then difficulty in eversion of upper lid, Gifford sign. Infrequent blinking, Stellwach sign. Conjunctive signs, these include deep injection and chemosis. Pupillary signs, these are of less importance. Ocular motility defects, these range from convergent weakness, Mobius signs to partial or complete immobility of one or all extraocular muscle. The most common ocular motility defect is a unilateral elevator palsy caused by an involvement of inferior rectus muscle followed by failure of abduction due to involvement of medial rectus muscle. Exophthalmos is most common in 60% of cases and classical sign of the disease. As a rule, both eyes are symmetrically affected, but it is frequent to find one eye being more prominent than another. Frequent is one eye being more prominent. Exposure characteristics and symptoms of ocular surface discomfort include sandy or gritty sensation, lacrimation, photophobia. Corneal exposure has been attributed to upper lid retraction, exophthalmos, lagophthalmos, inability to elevate the eye, decreased blink rate. Optic neuropathy occurs in about 60% of cases due to direct compression of nerve or its blood supply by enlarged rectus muscle at orbital apex. It may be manifest as papilloedema or optic atrophy with associated slowly progressive impairment of vision. Classification, it is classified by American Thyroid Association and acronym no specs. Class 0 N, no signs and symptoms. Class 1 O, only signs, no symptoms. Signs are limited to lid retraction with or without lid lag and mild proptosis. Class 2 S, soft tissue involvement with signs as described in class 1 and symptoms including lacrimation, photophobia, lid or conjunctival swelling. Class 3P, proptosis well established in class 3. Class 4E, extraocular muscle involvement, limitation of movement and diplopia. Class 5C, corneal involvement, exposure characteristics. Class 6S, sight loss due to optic nerve involvement with disc pallor or papilloedema and visual defects. No specs is the acronym. Clinical course is self-limiting disease and lasts over 1 to 5 years, longer in smokers or compared to non-smokers. Clinical course is divided into 2 phases: congestive or active phase of increasing severity is characterized by active inflammation with marked lid edema, conjunctival chemosis and congestion with increased exophthalmos. Within 2 to 3 years, in majority cases, there starts regression. Most of signs slowly settle down. Fibrotic or inactive phase, also known as quiescent burnout phase, ensues after regression phase. In this phase, eyes are white, however, a painless motility defect may be present. Diagnosis, clinical diagnosis. Clinical diagnosis is not difficult in advanced cases of Graves' ophthalmopathy with bilateral proptosis. However, early cases having unilateral proptosis need to be differentiated from other cases. Investigation, thyroid function test, serum T3, T4, TSH, estimation of radioactive iodine uptake. Autoantibody assay may include anti-TSH receptors, anti-thyroid peroxidase, anti-thyroglobulin, thyroid stimulating antibodies. Some of these have poor sensitivity and specificity. ultrasonography. It can detect changes in extraocular muscle even in class 0, class 1 cases, thus helps in early diagnosis. In addition to increase in muscle thickness, erosion of temporal wall of orbit, accentuation of retrobulbar fat, and perineural inflammation of optic nerve can also be demonstrated in some early cases. CT scanning may show proptosis, muscle thickening of optic nerve in anterior pallosa, orbital septum, etc. MRI gives better soft tissue resolution and identify active disease. Management, periodic clinical work, non-surgical measures, surgical management. Periodic clinical work, clinical activity score has been described to measure the active disease at a given time. Pain 1 to retrobulbar pain on ocular movement. Redness of lid, redness of conjunctiva, swelling of lids, swelling of conjunctiva, swelling of caruncle, proptosis. Loss of function, decrease in eye movement plus or minus 5 degree over 3 months, decrease vision by greater than or equal to 1 Snellen line over 1 to 3 months. Ocular motility workup field. In addition to eye movements, the ocular motility workup should also include field of binocular singulation, field of binocular fixation, lease charting to decide intervention required. Non-surgical management. Smoking cessation should be insisted with patients as it may be marked influence the course of disease. Head elevation at night, cold compress in the morning, help in reducing the periorbital edema. Then lubricating artificial tear of methyl cellulose instilled frequently in daytime, relieve foreign body sensation. Symptoms are dry ocular surface. Eyelid tapping at night prevents complication of exposure. Guanethidine 5% eye drops may decrease the lid retraction caused by overaction of Muller's muscle. Prisms may be prescribed to alleviate annoying diplopia till the quiescent phase is reached. Systemic serum may indicate in acutely inflamed orbit with rapid progressive chemosis and proptosis with or without optic neuropathy. Radiotherapy 2000 rates given over 10 days. Help in reducing orbital edema. Patient where steroids are contraindicated. However, radiotherapy may be transient to worsen the disease. Combined therapy with low dose steroids, azathioprine, radiation reported to be more effective than steroids. Surgical. During active phase, orbital decompression may be required for an acutely progressive optic neuropathy or exposure criteria in patients who do not respond to energetic steroid therapy. During quiescent burnout phase, the surgical management is required to improve function and cosmesis. Stepwise surgical approach starting with orbital decompression, followed by extraocular muscle surgery, followed by eyelid surgery is recommended. Alteration of this sequence may lead to unpredictable results. Orbital decompression, 2-wall decompression, 3-wall decompression, 4-wall decompression, in which 2-wall in which orbital floor and middle wall are removed, and 3-wall in which floor, middle wall and lateral wall are removed. Then 4-wall involves removal of lateral half of roof, large portion of sphenoid at apex. This allows 10 to 16 mm of retroplacement of a globe. Extraocular muscle surgery should always be carried out after the orbital decompression, since the latter may be extraocular motility. Inferior rectal recession is the most common performed surgery. Eyelid surgery, when required, should be undertaken last, as extraocular muscle surgery may be affected eyelid retraction. Botulinum toxin injected aimed at Muller muscle, LPS muscle, may be used. Mullerectomy, levator recession, decentralization, scleral graft with LPS, recession of lower lid retractors, blepharoplasty, etc. Carotid cavernous fistula. Clinical types. Carotid cavernous is acquired abnormal communication between carotid artery system and venous cavernous sinus. Then it's of two types: high flow fistula and low flow fistula. Differential in carotid cavernous fistula, retrobulbar hematoma, and superior orbital fissure syndrome, orbital apex syndrome. Treatment: carotid cavernous fistula requires a definite treatment, endovascular technique, etc. Then orbital tumors. Orbital tumors, primary tumors, developmental vascular, adipose, fibrous tissue tumor, osseous cartilage tumors, mesenchymal tumor, neural tumors, tumors of lacrimal gland. Secondary tumors, then spreading from surrounding structures, including squamous cell carcinoma, malignant melanoma, metastatic tumors from distant primary tumors. Then primary orbital tumors, developmental tumors, dermoids, superficial dermoids and deep dermoids. It arises from embryonic displacement of epidermis to subcutaneous location. Then superficial dermoid and deep dermoid. It is seen in infancy, seen in adolescent. Epidermoid composed of epidermis without any epidermal appendages in the wall of cyst. Lipodermoids, these are solid tumors usually seen beneath the conjunctiva. Then dermoid right orbit. Lipodermoid. Teratomas. Teratoma composed of ectoderm, mesodome, endoderm. Vascular tumors, capillary hemangioma. Hemangiomas are further divided into capillary and cavernous hemangioma. Congenital teratoma. Treatment: these tumors usually do not require any treatment. Systemic steroids. Steroids should be given. Cavernous hemangioma. Commonest benign orbital tumor among adults with female preponderance. Lymphangioma, uncommon tumor. Mesenchymal rhabdomyosarcoma, highly malignant tumor of orbit arising from the pluripotent mesenchymal cells. Histopathological embryonal sarcoma, alveolosarcoma, and pleomorphic sarcoma. Clinical features: rapidly progressive proptosis. Rhabdomyosarcoma. Treatment: surgical excision, chemotherapy, radiation therapy. Neural tumors, optic nerve glioma, meningioma, then optic nerve glioma, clinical optic nerve glioma, X-ray, foramina, CT scan, ultrasound US. Optic nerve sheath meningioma, clinical photographs show axial proptosis, CT scan orbital showing typical triple sign. Optic nerve sheath meningioma, it has triple sign. Triple sign is important. Then secondary orbital involvement patient with sphenoid ridge meningioma, clinical photography, CT coronal, CT axial. Then orbital blowout fractures, blowout orbital fractures generally result from trauma to orbit by relatively large, often round ball, tennis ball, cricket ball, etc., human fist, etc. Then the force of blow causes a backward displacement of eyeball with an increase in intra-orbital pressure, with a resultant fracture at the weakest point of orbit wall. Usually the point is on the orbital floor, but this may be medial wall also. Then glass fusion, pure blowout fracture, impure blowout fractures. Clinical feature: periorbital edema and blood extraction in and around the orbit. Mechanical blowout fracture of the orbital floor. Inophthalmos, mechanical proptosis with blowout fracture of orbit. Plain X-ray orbit showing herniated orbital contents with blowout fracture of orbital floor wall. Then emphysema of eyelids occur more frequently with middle wall than floor fractures. Paresthesia, anesthesia in the disturbance of infraorbital lower lid, cheek, side of nose, upper lip, upper teeth are very common. Ipsilateral epistaxis as a result of bleeding from maxillary sinus into nose is frequently noted in early stages. Proptosis of variable degree may also be present initially because of orbital edema and hemorrhage. Inophthalmos, mechanical ptosis. After about 10 days, as edema decreases, the eyeball sinks backward and somewhat inferiorly, resulting in inophthalmos, mechanical ptosis. Three factors responsible for producing inophthalmos are escape of orbital fat into maxillary sinus, backward attraction on globe by entrapped inferior rectus muscle, enlargement of orbital cavity from displacement of fragment. Diplopia, double vision, forced duction test. Presence of muscle restriction can be confirmed by positive forced duction test. Then orbital imaging it is done by plain X-rays, CT scanning, magnetic resonance imaging, etc. The common Röntgen findings are fragmentation, irregularity of orbital floor, depression of bony fragments, and hanging drop in plain X-rays. Then computer tomography, scanning, and magnetic resonance imaging, these are of greater value for detailed visualization of soft tissues. Management, general measures and medical treatment. Avoid nose blowing, should be advised to each patient, as the nose blowing may contribute to surgical emphysema and herniation of soft tissue. Systemic antibiotics, analgesic and anti-inflammatory, cold compression. Surgical management, indication of surgical intervention include diplopia not resolving significantly in the early days after trauma, a fracture with large herniation of tissues into antrum, incarceration of tissues in fracture for resulting in globe retraction, then increased applanation tension in ophthalmos greater than 3 mm. Orbital surgery, orbitotomy operation refers to surgical approach to or an orbital mass lesion. 4 surgical approaches: anterior orbitomy, superior approach, B is inferior approach, C is medial, and D is lateral approach by lateral canthotomy. Lateral orbitomy, then lateral orbitomy, in this approach lateral half of superior orbital muscle, supraorbital margin with quadrilateral piece of bone forming lateral orbital wall is temporarily removed. S-shaped brow skin incision is called Crowlin operation. Upper eyelid crease incision, lateral canthotomy incision, transfrontal orbitomy. In this technique, orbit is opened through its roof and thus mainly is domain of neurosurgeons. Exenteration of orbit, skin incision, A skin incision, B is periosteal reflection, and C is amputation of orbital content. Exenteration is a mutilating surgery in which all the contents of orbit along with periorbit is removed through incision made through orbital margins. Exenteration indicated for malignant tumors arising from orbital structures or spreading from eyeball. Nowadays, debulking of orbit is preferred over exenteration.